Good afternoon. Apologies to the public that we're running a few minutes late. We'll go ahead and bring this meeting to order. Susie, can you please roll call?
Chair Delgado,
Here.
Vice Chair Lucy, seems to be absent. Michael Brown.
Here.
Councilman Dare.
Here.
Dr. Danko.
Here.
Dr. Novak. Here. And Dr. Kalakin will be signing on shortly. Chair, we have a quorum.
Thank you very much. Councilman Dare, can you please lead us in the pledge?
Chair, we have a brief message.
Okay.
All public comment is limited to 3 minutes per person and should be addressed to the Board of Health as a whole, not an individual. With the exception of the public comment agenda items, comments will be heard for items labeled for possible action and should be specific to the item being considered by the board. The District Board of Health conducts the business of Washoe County and its citizens during its meetings. The presiding officer may order the removal of any person whose statement or other conduct disrupts the orderly, efficient, or safe conduct of the meeting. Warnings against disruptive comments or behavior may or may not be given prior to removal. The viewpoint of a speaker will not be restricted, but reasonable restrictions may be imposed upon the time, place, and manner of speech. Irrelevant and unduly repetitious statements and personal attacks which antagonize or incite others are examples of speech that may be reasonably limited. In accordance with Declaration of Emergency Directive 047, persons in counties with substantial or high community transmission rates will be required to wear face coverings while in public indoor spaces, regardless of vaccination status. This mandate is in effect in Washoe County as we are designated as a community with high transmission rate.
Thank you for those remarks, Susie. Any changes to the agenda, Mr. Kevin Dickoff, Health Officer?
Yes, thank you, Chair. Yes, we're going to be moving public
I think we'll
comments.
move forward with the way it is.
Oh, we are?
Yeah,
Okay.
yeah.
Sorry, my misunderstanding. No other changes to the agenda.
Seeing no changes, can I have a motion to approve the agenda?
So moved. Second.
Motion second. All in favor? Aye. Any opposed? Motion carries unanimously. Item 4, recognitions. Mr. Kevin Dickoff, Officer. Health Officer.
Thank you, Chair Delgado. I'd like to begin with recognitions for years of service. And if I could have Kathy Silbrio please stand to be recognized for 25 years of service as Public Health Nurse Supervisor. Thank you for your service to the Health District and our community. And as well, Corey Silbrio, also recognized for 25 years of service as a Public Health Nurse too. And thank you for your efforts. Most recently leading our team at the TB clinic. I should also mention Kathy has been active in our immunization, leading our immunization efforts and the vaccination efforts for COVID-19. Also like to recognize Christina Shepard, advanced practice registered nurse, who is at the 5-year milestone for CCHS, and I don't see Christina here. So she's busy providing service for our community. Also, Blair Hedrick is an office assistant too with EPHP, the Vital Statistics Program, with 5 years of service. And that was incredible timing, Blair. Just walked in, so I know she's busy at the Vitals counter today, but we're just recognizing you right now, Blair, for your years of service. So thank you and congratulations. And then we have some new hires that I'd like to announce. Carly Crane, an office support specialist that is joining the Health District. It's a promotion for her from the Recorder's Office, and unfortunately Carly can't be here with us today. We have James Smith also joining us as an office support specialist with CCHS. And he is also a promotion, but from Senior Services. And is James here today? Oh, there he is. So welcome. I don't know, Ms. Latris, if you wanted to make any introductory remarks.
James is a proud Nevadan, longtime Washoe County resident and former business owner. He has refocused his professional life to growth and hard work and serving the overall health of members of the community that he loves, and that has been a good for him and his family. So we are very glad to have him as a OSS in Topeka. Thank you. And I can stay.
Yeah,
Introduce Rachel.
welcome, thank you.
Rachel Ladd. She is our new medical billing specialist. Rachel has been a biller for 18 years and has lived in Washoe County for more than 20 years. She has worked at several major medical providers in Reno Sparks area in a variety of roles. She's happy to have joined the CCHS team and hopes to lend her experience to help our community.
Great.
Welcome.
Welcome
Thank you.
both. I'd also like to welcome Geraldine Diavola, who is a new media and communication specialist with the Office of the District Health Officer. I'd like to ask Mr. Oxenhart to provide us an introduction for Yara. This represents a doubling of our communications program for the Health District.
You beat me to that, Kevin. That was my joke. For the record, Scott Oxenhart, Communications Manager at the Health District. Very happy to have Yara on board. She worked for 6 years at the State Department or Division of Insurance, and she also worked at Univision as a journalist in both Reno and Las Vegas. So great expertise, and we're really happy to have her.
Awesome. Thank you, welcome. Good to see you.
Next, I have a promotion I'd like to announce for Alexandria Velasco, promoted from a public health nurse to public health nurse 1 to a public health nurse 2 in CCHS. So, Alexandra, are you here? She's busy working, so congratulations to her on her promotion. We have some retirements to announce. I don't believe that Denise Kona is here. But remarkable service to the Health District. Denise Kona has been an office support specialist in EHHS, and she retired in early November with 36 years of service at the Health District. So congratulations to her on her well-earned retirement. And then we also have retirements of Corey Silbrio, who we just saw hit his 25-year service anniversary. So Corey and Kathy Silbrio are both retiring with 25 years of service. And I do have a small token of our appreciation for each of them. And these are wrapped better than I thought they were. But they are clocks that say Washoe County Health District recognizes, and this one is Kathy's, Sobrio's, for her 25 years of dedicated service from 1996 to 2022. So thank you both for your great service. I'm sorry to see you leave, but congratulations on your retirement. And we have these clocks for you to hopefully remember us fondly with. And then I also have some resignations to announce. Julie Hunter has resigned as our Emergency Medical Services Coordinator. She also had served in our Air Quality Management Division, and so she has 15 years of service with the Health District. We wish her well. Megan Bowling, who's also resigning as a medical billing specialist with CCHS, is locating out of state, has 2 years of service with us. And Martha Cacique, is Martha here? Okay, she is, we have clocks for both Julie and for Martha, but Martha has 21 years and 7 months service with the courts for Washoe County, followed by 2 years of service with the health district. So wanted to recognize that extensive service that she's provided for us as well. And that concludes the recognitions that I have today. So thank you, Chair.
Thank you, and congratulations to all those that were named. Appreciate you so much for all the work you've done for us, especially those retirees and those that continue to be with us. And again, welcome to our new team. Appreciate you so much, and I know you'll love working here. So again, thank you all. Thank you, Mr. Dick. With that, we'll close item number 4. We'll move on to item number 5, National Radon Action Month proclamations.
Chair, for the record, Dr. Clacking signed on at 1:10.
Cool. Thank you.
All right, so we have a proclamation for National Radon Action Month. My understanding is Christine Kelly is not able to join us for acceptance of this. And she's with the University of Nevada, Reno Extension Program. Whereas many residents of Washoe County don't know about radon, yet need to know for the safety and health of their families, as radon is a colorless, odorless, naturally occurring radioactive gas that is the primary cause of lung cancer among non-smokers and the second leading cause of lung cancer for smokers. And whereas the U.S. Environmental Protection Agency estimates 21,000 people in the U.S. die each year from lung cancer caused by indoor radon exposure, and lung and bronchus cancer kill more people in a year than any other cancer. And whereas radon kills more people than secondhand smoke, drunk driving, and home fires combined. And whereas any home in Washoe County may have elevated levels of radon, even if neighboring homes do not, and living in a home with an average radon level of 4 picocuries per liter of air poses a similar risk of developing lung cancer as smoking half a pack of cigarettes a day. And whereas testing is the only way to know if a home has an elevated radon level, and testing is easy and inexpensive, and when identified, homes can be fixed. And whereas University of Nevada, Reno Extension's Nevada Radon Education Program and the Nevada Division of Public and Behavioral Health and the EPA support efforts to encourage all Washoe County residents to test their homes for radon, mitigate elevated levels of radon, and have new homes built with radon-reducing materials and features. Now, therefore, the Washoe County District Board of Health does hereby proclaim January 2022 as National Radon Action Month, adopted this 16th day of December 2021, signed Oscar Delgado, Chairman, Washoe County District Board of Health.
Awesome, thank you. And I know she's not here, but appreciate the constant information and education for our community about the need.
And if I could add, I think that if she was here, she would remind us that this is an ideal time of year to test your home for radon because you need to keep it closed up for several days, and this is the time of year you do that. So, thank you.
Great message. With that, we'll close item 5. We'll move on to item 6, public comment. Susie, do we have any public comment?
No registered public comment in that last item, Chair. Was it possible? It's an action
Oh,
item?
my apologies. Yes, can I have a motion, please, on the National Radon Action Month proclamation?
So moved.
Motion.
Second.
Have a second. Further discussion? All in favor? Any opposed? Motion carries unanimously. Thank you, Susie. Item 6, public comment. No public comment. Anyone in the audience? Public comment? Seeing none, we'll close public comment. Moving on to item 7, COVID-19 update information. District Health Officer.
Yes, thank you. Sadly, earlier this week, we reported our 1,000th death of a Washoe County resident from COVID-19. We're currently at 1,003, and we've passed the tragic 800,000 deaths milestone nationally from COVID-19. And so this is, terrible for all of the loved ones and families that have lost these people. My heart goes out to them. We also have exceeded 70,000 cases of COVID-19 in Washoe County. We stand at 70,141 confirmed cases today. And we are, hearing in the news about Omicron. We have a case that's been detected in southern Nevada. We're seeing rapid increases of cases that are occurring in South Africa and the UK. So we're monitoring that, but expecting that to arrive in our community, and it looks like it will have some significant impacts for us in the future. We have been fairly steady on the number of cases. We've kind of plateaued at the around 85 to 90 or so level of new cases as a 7-day average. Under the county tracking system, our test positivity rate is declining. It was down to 6.7% today. It was 7.8% on December 8th when I put my monthly report together. So that's encouraging news to see of the declining positivity. And on the county tracker, the cases per 100,000 over 30 days today is reported at 487. So while we have seen higher levels of cases and positivity with the surge that we had experienced recently, and Clark County was actually doing better than us over the past few months, we've now gotten down to where Clark County's levels were, and Clark County is moving up, and they have a little higher positivity in number of cases per 100,000 over 30 days than we do at this point. We do, however, remain in the high transmission category under the CDC. We're at 118 new cases, or 118 new cases over a 7-day period per 100,000. And the threshold between substantial and high transmission is at 100. And we are now below 10% on CDC's positivity over the prior 7-day period. We're at 9.59. So that actually does drop us into the substantial transmission category from high for our positivity rate. The mask mandate applies to both substantial and high transmission areas, and the CDC default is the higher of your levels from case count or test positivity. So under CDC, we are considered high because of our case count levels. As far as our hospitals, just this week, the Nevada Hospital Association removed the warning level for hospital occupancy rates, which is a good sign that's for the overall utilization of the hospital for all medical and healthcare needs. But we remain under alert level for staffing, and staffing is an issue that's occurring not only in our hospitals, but also in our long-term care facilities, as well as our pre-hospital care. And throughout our community, I think we all see staffing issues that are occurring. So the vaccination efforts are continuing. We will be transitioning from the drive-through at the Livestock Event Center after tomorrow, and we'll begin providing COVID-19 vaccines in our clinic indoors beginning next Monday. And we are planning a number of community events to be recurring, which we'll be announcing shortly, involving some libraries where we'll have a regular weekly pod occurring, and we're also working with the Reno Sparks Convention Center for space there in one of their convention halls. We are concluding, I'll call it a blitz of pods for 5 to 11-year-olds, 14 of them over 10 days. That is concluding those 14 through tomorrow in conjunction with Renown Health, Community Health Alliance, Immunize Nevada, Washoe County School District and the Health District. So we actually have 3 pods going on this afternoon: Duncan Traynor Library, Clayton Middle School, Matthews Elementary, and then tomorrow at O'Brien Middle School and Dilworth Middle School. And we will continue to operate our testing outdoors we feel that's a better approach for just the safety and preventing disease transmission of symptomatic people coming to be tested. We'll operate those testing. Currently, the plan is Monday, Wednesday, and Friday for 150 people each of those days, but we're also looking at demand and adjusting that schedule as necessary. With the holidays coming up, we will not be operating the testing on this next Friday or the following Friday, and the Nevada State Public Health Lab is actually going to be closed down after Thursday afternoon on both of those weeks. So we wouldn't have a place to send samples collected for testing if we were operating. So we are aware that ACIP is meeting today to discuss the Janssen vaccine, and I haven't seen anything come out of that meeting yet. I don't know if anybody else has seen anything, but we may have some news from the CDC in regards to Janssen from those discussions today. That's what I know at this point. So with that, I don't know if Dr. Danko, you've had anything that you wanted to add on the medical or hospital front?
Thank you. And I think from a hospital front, it continues to evolve. We see the trends are different in the hospital, as generally those who are hospitalized with COVID infection tend to be in the hospital for sometimes a prolonged period of time, sometimes upwards of weeks to months. So sometimes when we see improved trends in the community, it takes time for us to see those improved trends in the hospital. We can still have fairly significant volume and severity of COVID infection inside the hospitals and nursing homes. And beyond that, as we've learned through this 2-year process almost, this virus will continue to evolve. So we have to stay vigilant with our efforts in prevention. Still, our best preventative tool are the vaccines that are available and now widely available and now here for a long time. And so many across our country and the world have been vaccinated successfully. We certainly see a hospital trend that trends more towards unvaccinated individuals, and very much so, not just a little bit. The boosters also, I'll make a point now that we've had so many people that were vaccinated earlier when the vaccines first were available. I think boosters really help to boost the immune system and give us more fighting power even against those variants. So getting the boosters, if you're eligible for those, is definitely an important piece as well. And just for us to not forget that it's colder outside, so more people shift inside to stay warm. And with the holidays, sometimes we have celebrations with more people. And again, on the prevention front, I can't say enough about masks and wiping common touch surfaces and continuing to be careful with your exposures and keeping those distances. And especially because we're also in co-occurring flu season, and sometimes those infections like to co-infect. So I think just vaccination and continued efforts in prevention is our best tool. With respect to the treatment medications, we don't have that many changes since October. There are a couple of new treatment medications that I believe are in the process of possible authorization or approval, but we are not yet at the point where we are using those new treatment medications yet at this time.
Great, thank you. Actually, if I could just follow on the boosters. Community-wide in Washoe County, our 4-week moving average for vaccinations, COVID-19 vaccinations administered is 13,382, and about 60% of those are boosters, third doses or boosters that people are getting now, third doses for immunocompromised, boosters for the others following their initial series of vaccinations. And we just hit the 1-year anniversary of receiving the first shipment of vaccine. I'll never forget that arriving in our parking lot and Mike White going out to meet the delivery and bringing that in. But you know, the health district in our community has been working very hard since the vaccine became available to make sure that was getting in people's arms where it could be effective. And as far as the doses of vaccine administered per 100,000, Washoe County stands at 136,368. Clark County is at 117,364 doses per 100,000 population. So they're 19,000 doses behind us per 100,000 for doses administered. The Quad County Health District area is at, the health authority area is at 120,000, just over that, doses administered per 100,000. So we're about 16,000 doses per 100,000 administered ahead of them. And the rest of rural Nevada stands at 93,487. So we're almost 43,000 doses per 100,000 ahead of that area of the state. So I'm very proud of the health district as well as all the partners that have joined us. The National Guard stepped down on Monday. They've been a great help to us. Our MRC volunteers continue to give and are supporting our efforts. I appreciate them, but all of the other providers in our community, our pharmacies, our healthcare providers that are dispensing the vaccine, administering it. The health district accounts for just a little under 10% of all of the doses administered countywide currently. That includes our homebound vaccinations, our community pods, and the vaccinations we've delivered through the Livestock Event Center. So, thank you.
Yes, comments for questions?
Yes, a quick question is, so you mentioned masks, and so according to the CCC is what we're following now of why we're continuing to wear them is because of the percentages they put out of what they seem safe. What will dictate when this can actually come off our face? How do we know we've reached the right level? What hope does someone have when we sit back? It seems to be lingering. I mean, it just feels like that. And with that said, I don't want a moving target, obviously, and that gets frustrating. So is there a target? And when that happens, when we reach that, then we are then waiting for something from the state to tell us? Or are we able to say, hey, we've reached our level, we move forward? How does that work?
So the mask requirement is under the governor's directive. And so his directive says that the CDC recommendations will be what is required for people wearing masks in Nevada. And so the CDC's recommendation on masks is based on those the level of new cases, the transmission thresholds at the county level. And so if we're in high or substantial transmission under the CDC requirements, the mask requirements under the current directive would remain in effect. I don't know what plans there may be, if any, in regards to that directive. I don't know if the CDC is evaluating any of those things. I do know with the increase in cases nationally that are occurring, we're seeing other governors that are reinstating mask requirements in other states because of high levels of transmission.
Good question. Any other comments, questions for none? Thank you, Mr. Kevin Dick, Officer. I think, I know we recently heard action that was taken by the Washoe County Commissioners. I've received many calls. There seems to be a lot of confusion associated with what the action they took and what is still asked and required by the governor with respect to business and other things. Are we going to put out any more clarity in terms of information as to what's required by our public and what was taken by those and so forth?
We can reinforce the communication on the mask mandate being in effect for Washoe County. The Board of Commissioners decided to terminate the emergency declaration that the county has. And that emergency declaration was important for us early on in the response, in that it allowed for us to move quickly and removed some of the requirements for establishing contracts, purchasing PPE, those types of things, so that we could be more nimble and respond quickly. It also allowed for the county and the cities under their emergency declarations. Those declarations allowed for reimbursement through FEMA for costs of the response. We're in a situation now where we have had the federal government step up and provide us with grant funding that we're using for our COVID response efforts now. And so with that funding in place and having our operations set up and ongoing, the need for the flexibility that's provided under the emergency declaration has diminished. And so I don't see the health district's operations being directly impacted by the emergency declaration being terminated by the county. But it doesn't change the mask requirements under the governor's directive. I think primarily is just to ensure that all of the financial and contract procedures and whatnot are done as they are normally done through government.
Good. I know there's a lot of confusion with respect. So it sounds like in summary that what they really did is move back to just general operational and infrastructural components. Is traditionally what they've been able to do, but it does not in any way say that the pandemic is over or that no masks are no longer warranted in indoor buildings and will continue moving as accorded by the governor with respect to indoor policies. So, yes, Dr. Novak.
This big brought up the fact is Mr. Dick brought up the fact is the county is only, as far as the health department, is doing 8% of the total vaccines. I'd like to see a real breakdown, not just blanket state numbers of who's doing this kind of stuff. You know, talking to one of the other probably bigger vaccination people, they said, you know, told me some of the numbers. They don't come anywhere close to what the health department's doing. And I know we're in a very tough transition state right now. And I'd kind of like to see a real breakdown of who in Washoe County is doing all the testing. If we're only 8%, because out in the cold in the real world out there, we're doing a lot of people. We did almost 1,200 in the pod last week alone. So I'd really like to see that.
Yeah, our 4-week moving average for the health district is 1,326 for the week. I don't know if I can get those numbers. I can request them from the state, but I don't know that they can provide us with the granular numbers. They haven't previously.
I know they haven't. I know it's difficult.
Yeah.
But I'm also just real concerned about the validity of what you're being sent. I know we're not generating it, but I'd like to see who's doing all these things. Because we've got pods outside, inside schools, outside, you know, in the parking lots. I just kind of have a doubt whether we're 8%.
Yeah, that would be great to, transparency sake, see who's doing what, if we're,
Yes.
how much we're doing, what's the nonprofit world doing, what's the hospital, maybe more. Yeah, okay, Councilman Dare.
Yeah, I just want to offer clarification too on the emergency removal portion. This is pretty typical for cities, counties to implement and actually take back, because some of the processes of where it gives our county manager, city manager jurisdiction, how they make decisions, where things happen. It does not mean that at some point they can't decide that we've hit a new something and they put something back in motion. This is one of those things that I think is important, that I know for me as a city, if I'm a city councilman, this is what I chose, something that I would hope people would understand that's my job to help do in my city. I'm not in, I have nothing to do with what the county did or didn't do. That's none of my lane. But I would say, for me, I think county will do what they need to do, just as Reno will do what they need to do, and so will we. And so, with that said, it's pretty typical, normal business when it comes to the city that we have emergencies that come and go. This might have a lot more fodder to it because of some of the other conversations around it, but if you just take this for what it is, which I would encourage us to, it is just doing what we do as a city or a county all the time. So that would be my clarification. I would hope we can understand.
Further comments? No? Real quickly, I attended a pod yesterday at Dotson Elementary School. A lot of kids, a lot of families, a lot of folks getting their vaccines, very excited. And really, one of the takeaways for me is that many of the little ones were really excited to be able to go and see their grandparents. That's what they kept telling me, is like, I'm gonna go see grandma and grandpa for Christmas. And that was kind of their friends, school, and so forth. That was family. And that was just interesting to me, my takeaway of talking about 10 different little kids at Dotson Elementary School. So thank you to all the providers out there, all the nonprofits that are doing the work out in the community. So appreciate that. No more comment related to item 7. Any public comment on 7? Okay, we'll close item 7, move on to item 8, consent items. Looking to the board for, if you want to pull anything.
I do have one question on item D. I just want to understand it more. Part of it has to do with the amount that's there. I looked at it, I tried to read to understand, and it's just making sure that we have $3 million heading in the right direction, how that's going. Can we get a lot more explanation on that?
So we'll pull item D.
Yeah.
Any general public comment on the consent agenda, Susie?
No registered public comment.
Okay, any other items that want to be pulled? See none, can I have a motion to accept the consent items?
Motion to.
I have a motion, second. All in favor?
Aye.
Any opposed? Motion carries. Moving on to item D. I can get a report for Councilman Dare, District Health Officer.
Yes, so yeah, this is just an eye-dropping or jaw-dropping figure of $3 million. And we do have grant funding for, this is for the temporary staff that we're using to help support our operations. So both the pod operations, testing operations, the vaccination operations, testing operations, disease investigators, contact tracers, call center staff are all provided. We get some of them through these temp staff from My Next Career Path. And we had an existing purchase order with them that was at $1.5 million. And this is to increase the purchase order amount to $3 million. That doesn't mean that we're going to spend all of this money, but it gives us the ability to continue using them for that staffing up to that level. And that's because we're coming up on the $1.5 million that we had already approved.
So just so I understand it right, so this is not necessarily paying, we're not paying a bill of $3 million. We're putting something in motion that allows us to, in the next year or whatever season. Okay, thank you.
Yeah, it's a purchase order that then they can invoice us under that, and we can pay those invoices as they come in, but they can't go past $3 million without additional
Understood
authorization.
that. And then this is out of some grant money that we got to help pay for that
Correct,
particular
yeah.
thing. That's why it says.
It's through the
protected
CDC.
budget. Okay, thank you. It all, I'm sure, is whatever, but I see those kind of numbers and I don't, in consent, I don't like those numbers in consent items, so.
Doing
thank
your
you.
job.
Thank you for those questions. Any further comments? See none, can I have a motion, please?
So moved.
Motion and a second for the discussion. All in favor?
Aye.
Any opposed? Motion carries. Thank you. Close consent items. Moving on to item 9, remsa. 9A, review and acceptance of remsa health operations report.
Good afternoon, Chair and Board. My name is Dean Dow, President and CEO of remsa Health and CareFlight for the record. You've had the opportunity, I hope, to review October and November's information, and here to answer any questions. And also just note that on 9B and 9D, we've got Aaron Abbott and also Adam Hines will be presenting 2 different reports that you've asked for.
Any general questions for 9A for Mr. Dow or his team? I do. I just have some general follow-up. I know you guys have spoke that back in November you guys had an academy. How's that going? Is that supporting or helping in terms of general compliance and response for new hires with respect to?
We've currently had a successful, I think, fall relative to retention, also recruitment. But to your point, yes, we've had several new classes, and those have been very successful. The candidates have passed out of their training successfully and are in the field working at present.
Any general comments? No from anything? No? Just Mr. Dare, I see you pushing your button.
Yeah. Hi. I just want to, overall, I know this is a Christmas time, things start ramping up actually again. How are we doing? I say that, how's the staff, everyone doing stuff? And are you having a Christmas party we're invited to or anything like that? And all that kind of stuff, how things going?
Do not feel bad. You weren't left off the invitation list for the Christmas party because we don't have one. We haven't had in 5 years. I'm a Scrooge. Shut that down several years ago. But overall, I think what you'll hear in Aaron's report and also Adam's report, that some of the stresses that the system faced through the summer and the first part of fall have started to sort of balance out a little bit. We've done a tremendous amount of work with all 3 of our health systems in the sense of the flow, if you will, of moving patients through the EDs and getting them admitted, et cetera. And that's been, I think, as many of you, we've had a lot of conversations with everybody, but as many of you know, that's been a very, very, very aggressive effort on the part of Northern Nevada and St. Mary's and Renowned and our organization. And a lot of components to that. And but I think all of us have worked tirelessly to try to make this work as best we can make it work for the population, the number of people that we're encountering. So our hope right now is that things are going to balance a little bit. But as we also know, and has been noted earlier by Dr. Danko and Mr. Dick, that wintertime is here, and so we're being very cautious about what we're gonna see over the next couple of months.
Mr. Dow, forgive me. My papers got mixed up. I know we have the Truckee Meadows agreement.
Yes, sir.
I believe it's in item A with respect to the operations reports. You added somewhere in there that we added Spanish Springs.
Yes.
Is that data now part of the overall compliance reports, or is that something separate in terms of
Spanish Springs won't be in October and November. It will be starting in December, correct, moving forward.
But Sun Valley and Wash Valley and everything else is currently included in terms of your data?
Those are in.
Data.
They should be at least November report.
Okay.
I can speak to that now or in the next.
Yeah, that's fine. The next one is good. Thank you, sir. Any further comments? Seeing none, possible action, can I get an acceptance of 9A?
So moved.
A motion, and all in favor? Aye. Any opposed? Motion carries. Thank you, Mr. Dow. Item 9B, remsa Health Response Times and Hospital Delays Update.
Good afternoon, Mr. Chair and members of the board. This is in response to some information that was requested and some discussion that was had at the October meeting. So I wanted to provide a little bit of information that was being inquired about and, be able to answer some of the questions. Some of them you brought forth
Good.
just a few minutes ago. So if I could have the presentation up, please.
It's a bad color.
It looks like we're having a little bit of difficulty, so I'm going to display it on my end, and then you let me know when to advance.
Okay. Okay, next slide, please. So one of the questions was just simply, trending in as far as response times goes. This is pretty typical. July, August, September do dip down when it comes to response times trends. October, November have increased a little bit, but that's nothing really out of the unusual. It's just the overall average response time that's, about 90 seconds to a minute higher than we like it. So there's not a lot that can be gleaned out of this. Just like to show the comparison between, City of Reno, City of Sparks, and areas out in the outside Washoe County. This is not information that is surprising. The further out you go, obviously the longer the response times get. City of Reno does, and I'll show in some of the upcoming slides, obviously has the vast majority of the entire call volume. They have a corresponding percentage of late runs to those number of responses, and the relation to Sparks and to Washoe County hasn't changed much, just really the sheer volume of calls that we respond to. There were also questions regarding hospital delays. So we've been battling the hospital offload delay issue for quite some time now, really since the start of COVID. Much of it is related to staffing levels. We really came to really sort of what we considered an emergency situation back in November. That number that you see there back in November actually represents 40% of all transports per day were being delayed getting those patients transitioned into the EDs starting in November. Back in November, excuse me, I keep saying November, I mean September 7th, 8th, 9th, 10th. We had a significant number of delays, up to 40% of our offloads. We called some emergency meetings with the ED directors at the hospitals, and we started meeting every day throughout the weeks, started identifying individual issues at each location. We looked at our divert policy. We have a region-wide divert policy. When one hospital gets inundated, then we close transports to certain types of patients to those hospitals to try to move patients to other locations at other healthcare facilities to try to alleviate that burden on the one hospital. And what we were finding was that we were just continuously inundating every hospital. So we changed how we actually diverted ambulances to hospitals. That made really an initial significant impact. You can see between the 7th, 8th, 9th, 10th, and 11th of September into the September 15th and on. We continue to meet with our hospital partners. We actually continue to meet multiple times a week. And if you look toward the end of November there, you can see on 11/27, we're down, that number represents about 5% of total transports. So we went from 40% of total transports being delayed offload into the EDs down to about 5%. I will caution that although those numbers we're pleased with that, we're very happy, and we have been extremely pleased with our hospital partners and the dedication that they've had to helping us with this issue. We're still representing about 190 lost unit hours trying to offload patients at hospitals during the month of November. That is down from about 750 to 800. So it is a pretty significant decrease in total lost hours, but it is still higher than we'd like it. We continue to work on those issues with the hospitals. Next slide, please. There was a question regarding mutual aid responses. going back to July, and maybe even a little bit earlier, we did start using mutual aid partners quite a bit more than we normally had been. Reno Fire particularly went from single digits a month to almost 50 times a month being used for mutual aid responses. They have one ambulance. It's at Station 19 out in Somerset. And we were starting to pull them in on at least once to 1.5 times a day sometimes. We have, if you fast forward up to November, we have had made a pretty significant impact in the number of mutual aid requests. That does seem to correlate with, getting our ambulances cleared out of the hospitals a little bit quicker, hospitals working with us to help us get ambulances back in the 911 system. There were several situations where Reno Fire would, we'd call them into the system for mutual aid response. They'd one run incident and they're on the wall waiting to offload their patient with us in the hospitals, which obviously is not a good utilization of that resource either. We did start, beginning in September, started staffing. We actually have a shift line that we fill every day at a pretty hefty overtime rate to try to encourage our paramedics who are off for the day to pick that up. And we do staff those folks into the EDs that are having difficulty with offloading patients so that they can monitor those patients and clear the ambulance. They're a force multiplier. I don't have the numbers for you in front of me, but that is on our daily schedule now, and they spend a significant amount of time assisting in the hospitals. I would also like to make a note, it is noted up there, Medic 30 and Medic 45 for Truckee Meadows, those numbers are really high by design. If you go back to August and September of 2020, we began utilizing them in their response district. So 45 is up in Sun Valley, Medic 30 is down in Washoe Valley, as a first due ALS provider on auto aid. So as an automatic response, we started using them in those areas. That's why their numbers are significantly higher than Reno Fire, for example, or Story County. Story County would come sometimes into the east end of Sparks, which is why they show up there. That's not an uncommon mutual aid request from them. So actually, in regards to the question regarding Truckee Meadows, beginning in November, Truckee Meadows became a subcontractor of Remsa Health. So that essentially solidifies their role in their district in responding down in District 30 and 45 as a first due. And then beginning in December, so December 1st, we did work with Truckee Meadows. We leased them an ambulance, and we actually have an ambulance staffed up in District 46 in Spanish Springs. And I don't have any data for you yet. Obviously, that data just began a few weeks ago, but we are noticing a pretty significant impact in the Spanish Springs area, which is in recent years been more and more difficult to get to based on congestion if you're not coming from that north end above McCarran Boulevard and Pyramid up in Sparks. So.
Councilman Dare, were you, oh, okay. I thought you, please.
I got a question.
Yes.
So that ambulance that you just put in service at 46, is that staffed with?
Chief, if you grab the mic.
The ambulance in 46, is that staffed with REMSA employees or fire employees?
It's cross-staffed with Truckee Meadows employees. Next slide, please. There were some questions and some desire to kind of look at some heat mapping when it came to response areas, zones within the county that seemed to be hot and not hot. This is a big overview. The next slides will kind of zoom in on some areas a little bit more granularly. But not surprisingly, as mentioned before, the city of Reno has the vast majority of the call volume. And when you look at this heat map here and go to the next slide, please. It's actually broke down into two pretty distinct sort of blobs of activity. The downtown area is not unusual, That area is historically our highest call volume area, right? We have a lot of density, tourism, et cetera. But the other blob is new. So the one on East 4th Street, that far down 4th Street in Commercial, that is location of the new CARES campus. The two addresses at the CARES campus actually combined make our highest number of priority 1 responses in the entire county. And that's since the opening of the CARES campus. Next slide, please. You can actually, we capture a little bit of the heat mapping. We wanted to get this section of Sparks and in relation to what we see out on East 4th Street as well, because there is actually along 4th Street a lot of activity along that 4th Street corridor, and some of it does run down Prater Way as well into the city of Sparks. Next slide. Down in this area, we have some pretty large assisted living and skilled nursing facilities. We also have some high-density apartment living areas that do create a pretty decent amount of call volume in this area. The next slide, please. And then I just wanted to look out in West Reno as well. No surprises there. The only thing of significance that is glaring to me is obviously you have this pretty large span of non-contiguous volume between the areas of Northwest Reno and Somerset. Based on population, that's probably not a big surprise, but it does seem to stand out, but nothing significant as far as volume compared to the rest of the system. And then next slide, please. Yep, thank you. And then this is just down in the areas of South Reno, Cody Ranch. There's some pretty significant development that's happened. If you look in the upper right-hand corner up there, there's a lot of new housing that's been built out there the last couple of years, and it sounds like there's also another area east of Damani Ranch, South Meadows area, that's going to have, I think, about 800 or so addresses in it that isn't fully populated yet, but we anticipate that it will be soon. Next slide, please. And then we can just take a look at the late responses. I don't think there's going to be a lot of surprises here, as the number of lates tends to correlate with the number of the amount of volume. So next slide. So these areas, are the same kind of bright spots. That one out in West Reno, we didn't talk about and didn't really show up significantly on the number of responses, but it does show up pretty significantly in the number of lates, and there are some, again, large convalescent facilities over there, as well as a couple of high-density apartment complexes that do end up generating quite a bit of call volume. Again, interestingly enough, the CARES campus location actually, the area around the CARES campus also not only generates the highest number of late runs, but also, the highest number of priority 1 calls also generates the highest number of lates as well. We often get multiple calls coming through at the same time at that location, which creates difficulty getting vehicles to. Next. This is that same area down along South Virginia Street, Plum, Lakeside, that area where there's convalescent and a lot of apartment living. Just high density tends to create high density volume. Next slide. Lemon Valley is sort of an emerging area where it's becoming harder and harder to get through. If we're still kind of looking to better understand that area. I think that traffic and congestion do seem to be playing a role, but it's still a little early. This is something that seems to have cropped up fairly recently over the last 6 to 12 months as an area that we need to focus on. Next slide. And then wanted to show the north end of Sparks and in the Spanish Springs area of the county as well. And so we do have pretty significant number of lates over the last several months, probably 6 to 12 months, starting to kind of show itself out there as well. We did start to see sort of a migration of some of the volume during COVID with a lot of people working from home, and those are bedroom communities out there, and they're a distance out there. Pyramid Highway is not quite as fast as it used to be to drive out. So it's an area that we have been focusing on as well. Next slide.
Can I ask a question?
Yes, sir.
What would you say you're focusing on that? What does that mean?
We started measuring the.
I'm focusing on it right now, but nothing's changing. So what does that mean to me when you say we're focusing on that? You guys putting more people out there? You guys?
Well, yeah, so good question. We have actually, because one of the areas that we did notice out in Spanish Springs were within driving distance and response distance from the Truckee Meadows Medic 46 station out there. That was one of the reasons why we did sit with our partners at Truckee Meadows and work on a way to staff an ambulance out there 24/7 through a partnership with Truckee Meadows. So, and they do have a boundary drop agreement with Sparks, and so they're actually able to reach quite a few areas out if they drive east down, I believe it's La Posada or Eagle Canyon, that direction toward the residents out in the north end.
Have you seen a good shift since? I mean, is that helping?
It just started in December. It's December 1st. And it's still a little bit early to tell, but anecdotally, observationally, we haven't, like I said, I don't have any data for you on that yet, but it does look like that it is causing an impact, a positive impact.
Thank you. Appreciate it.
General, I'm sorry for clarity. So you guys have contracted out with Truckee Meadows Fire to help support you in the city of Sparks.
At Station 46,
But they go into the city of Sparks jurisdiction.
they do, yes. Yeah, okay. Through their agreements with Sparks Fire, they have a boundary drop in that area.
Okay, just for clarity.
I think it's the next slide I need. Yeah, yes. So I just wanted to also zoom in on this area. This is an area down in Curdy Ranch, just showing the south end of Reno down here and how that area is visually represented on late runs in the system. Next slide. And we also wanted to just, we're just zooming around different parts of the county here. Washoe Valley does seem to, from a late run perspective, it doesn't even show up in contrast to the rest of the system. The call volume is very low. Number of lates down there is very low. And as mentioned before, we've subcontracted with Truckee Meadows for Medic 30, which is down by Bowers Mansion, and they're able to reach some of these areas as well. Next slide. I mentioned the CARES campus. I just kind of wanted to show you some of the numbers of the CARES campus. In August, we were seeing over 270 Priority 1 responses to the CARES campus a month, which is pretty significant. We actually did a similar process. We started meeting with their leadership, and they've been very responsive, and we're very pleased with the things that they've been able to communicate with us. And we were able to, I think, see a pretty significant reduction starting in September, October, and November with the CARES campus. And we continue to speak with them on a fairly frequent basis to try to better understand the needs of the population there and help educate their staff on what we do provide as an emergency service, what we don't provide, and how we may be able to help them seek care otherwise. The late responses, again, were pretty significant for a period of time. We're down to a couple of lates a week, which I think is a positive turn. So we were pretty high in October, and we were able to kind of turn that around. But I think as the CARES campus continues to mature and services are brought into that location, then we'll start to, I think, have a better data set that'll be more positive in the future, so.
Chair, can I just, real
Yes,
quick,
please.
can I have a request? I'd be very interested in when December's done, maybe sitting down, just sparks fly. Looking at this, it causes me concern. So I don't want to just linger on it. I'd love to sit and kind of look at some things there. And so I just ask, once December's done, that I can know about for December side of things, for Sparks.
Oh, sure.
Looking at this, it would seem that that's our heated area
Yep.
very much. And then I would like to talk initially at some point about the CARES campus. Obviously, that's a big concern that all of us, we know why it's there. And I just wonder if there needs to be some kind of approach where there is a health,
On-site.
something on campus, so we're not constantly bringing everybody, requiring remsa to keep running over there,
Right.
when we obviously know the need is pretty clear.
Well, my question and follow-up to your responses for those priority one calls, you have the front-end data of how many times you get called out. Do you have the back-end data on the actual illness acuity there, or whether some of that could be served with a different level of care, such as telehealth or some type of a consult service that's not an ambulance service? Because I understand you have to respond to a priority one, I'm assuming based on chief complaint, right? Such as chest pain versus stroke-like symptoms. But is there the possibility that some of those calls come in as a priority one, but then don't actually require transport to the hospital versus just on-site treatment that could be served at a different level of care?
Dr. Dankel, let me address both of those. One, relative to the CARES campus, there's a tremendous percentage of the initial priority one calls from that campus. And once we arrive and do assessment, they're low acuity to no acuity at all. There's unfortunately an understanding with that population of what the key words are, if you will, during the initial EMD process to execute a response. So they know those words and use them well. So there is, and we're working already with the CARES campus and with the county to sort of understand how to better educate their staff around the process. Also, the county is looking at bringing on nurse staffing to the CARES campus to help alleviate a lot of this. And Councilman Deere, your question about the CARES campus was, I forgot,
I know we wait for a phone call. I'm just wondering if we could do something, whether it's working with you all or with one of our health partners, to get something on campus there.
yeah, that's what I was gonna say.
Because there's no reason you guys, this is your hotspot. And
Like I said, we've already had discussions with the county relative to them hiring nursing staff and other sort of, if you will, medical professionals to be on campus as much as humanly possible. I don't think we're gonna achieve 24/7, but I think we are gonna achieve probably something in the 12-hour range, 7 days a week. And that's gonna be a tremendous load off of us, because right now we're getting called to go down and put, somebody on a cot, to clean them up, et cetera. And so as you saw in those numbers, it's stressed. If you put that component with the other components that we've had since summer and fall, it's stressed the system, as you know.
Do you have any data on what percentage of those priority one calls actually require transport to the hospital?
I do not have it in front of me, but I can pull it. Yeah,
That doesn't actually get transported to a higher level of care?
yeah. We can look that up. This slide just represents, by jurisdiction or by community essentially, what percentage of area draws the most late runs. Obviously, the city of Reno also has 60% of the total volume. So it's not unusual, and this is not, unfortunately, doesn't provide much insight, but just kind of shows you the breakdown. I also wanted to just touch on, last summer, we had a lot of discussion around ILS units and using ILS in the 911 system. for quite a few months, we had taken the, think big, start small approach. We wanted to walk into this carefully and make sure that we're able to execute an ILS response to a 911 call safely. It's something that a lot of other communities do, but this community has not up until this point. And so I just wanted to show some of just quickly the progression. We went from, if you just look at the last few months, from in July in the 30s, ILS units responding to 30-something ILS qualified 911 calls a month to now in November about 129. That number continues to grow. That, in my opinion, is a good thing. That means that we've safely and well matched ILS scope of practice to low acuity 911 callers in a very safe way. I'm also happy to report that we've not had a single poor outcome with a patient. We've, from a dispatch coding perspective, done a great job of identifying those callers early on and staffing ILS qualified units out in the system to be able to run those calls. So this is a good thing. The opportunity by the numbers actually is somewhere closer to about 500 a month that actually meet that criteria. We're only limited by the number of staff we have out on those units. We still do not supplant ALS staffing with ILS. Our ALS system is designed around total 911 call volume, and our ILS staffing is supplemental, but does not supplant the ALS system. So I want to make sure that I'm clear about that. And then on this last side, obviously there's unprecedented numbers of challenges that is our country, to be quite honest with you, nationwide is facing and dealing with. These are some of the action items over the last 6 months that we've put into place. We did actually lease 2 ambulances to the city of Reno for a period of time when we were seeing extreme high call volume and having extreme wait times in the EDs for offloads. That's no longer active. They were not staffing it, and in fact, I don't believe they even went on a single run, but we had them there for surge capacity just in case, and we were very thankful to the city of Reno for us being able to do that with them. We have been meeting with the CARES Campus leadership starting in August to try to work on some of those CARES Campus issues. We institute weekly hospital partner meetings, as I had already stated, to address offload time starting in September. We've been staffing paramedics in on a shift line that as soon as someone's delayed in the ED, those paramedics go out over there to help facilitate the offloads with multiple ambulances. They're a force multiplier. If there's 5 ambulances sitting on the wall, that one paramedic might be able to take 5 low acuity patients and kick those 5 ambulances loose. We've increased the number of ILS units, as I just discussed. As of September, we have 7 of those units on per day, and we continue to grow that staffing as our staffing models allow. We've added Truckee Meadows as a subcontractor of remsa up in Sun Valley, Washoe Valley, and then, as mentioned, starting December 1st up in Spanish Springs as well. And then our go live date for dispatching Truckee Meadows actually was yesterday. I'm pleased to announce we've successfully implemented that. We continue that through today without any bombs going off or explosions or sky falling or anything of that nature. And what's really great about it is now we actually can see all the resources by GPS between remsa and Truckee Meadows. So we see all of them. We see where they're at, if they're going to the grocery store, if they're coming back from a call, if they're wherever they are. And even just this morning, we were able to actually divert off a Truckee Meadows ambulance that we wouldn't normally have seen in an area to a priority 1 COVID positive breathing problem patient. In an area that would have taken us much longer to get to. So those opportunities are presenting themselves quite nicely at this point. So with that, I will take any other questions you might have.
Any general questions for Mr. Hines? Yes, Chief.
Great report, thanks. And, under the mutual aid responses, so you have contracts in place with the local fire department. So it's not really mutual aid, it's contracted services. Maybe we broke those out, you might be able to get a clearer picture, because it's not mutual. You contracted their first responders, their airport services. And maybe in your upcoming reports, when we break it out, we could actually see what's transpiring with those contracts.
So let me make sure I understand that. So correct, Truckee Meadows, as of November, really that no longer is considered mutual aid. So that data is then being pulled in the system. So thank you for reminding me of that. And then when it shows Reno and Story County, those are on mutual aid agreements. Okay. So that's clarification for that data. Thank you.
I think, if in the future you get further contracts with other agencies and break them out the same way, that would help to see exactly what's taking place on mutual aid.
Great.
So direction moving forward that they'll be more clear separated. And this is part of 9A. But just remember a side comment. I know looks like you guys are doing a great job in terms of people. There was one comment that says the ambulance was too small. They were trying out a new type of van. It was difficult to get in and out of. It was hard for the medics to do their jobs with him inside. It sounds like it was a newer van. Have we figured out kind of maybe it was something to change, or is that?
Well, it's difficult to. It's a difficult conversation to have. I think here there's a lot of factors involved in that. Obviously, that might be that patient's perspective. Based on one comment, I don't see us changing, how we're doing ambulance acquisitions. One of the challenges we do have, and this is again a national problem, the availability of ambulances. If we were to order the exact type of ambulance that we'd want today, it would probably take us about 12 months to get one. Yeah. So that is actually one of the reasons why we're leasing an ambulance up to Truckee Meadows and up at Station 46, because they have ordered an ambulance, but it's going to take them probably 9 months to 12 months to actually receive it. And when we, are trying to staff and operate 45, or so ambulances, when we lose a couple because the engines blow up or the rear end's grenade or something like that, and it's not repairable, and we need to buy an ambulance now, sometimes that's what's available, and we're going to take what's available so long as it's safe and prudent, and we can get the job done. So
just more of a question as, you try new things, try different models and so forth, and you go back and go, maybe it didn't work out for our purposes or whatnot, but just wanted to
sometimes
ask a question or glowing reviews or outside of that, so appreciate that, but just don't just jump that at me. Gotcha.
Yeah, they complained that it was too bumpy.
Yeah.
That was so because it's on a truck chassis,
yeah.
so it's a little bit of a double-edged sword.
Well, thank you, Mr. Hines. With that, on NB, any further comments? Seeing none, we don't need to take action on this. We'll appreciate your report. Item 9C, public relations.
Good afternoon, Mr. Chairman, members of the board. Alexia Jobson, Director of Public Relations for remsa Health, for the record. You have for your review the public relations report for October and November, and I have a few other things to share with you in particular today. In early November, in conjunction with the end of daylight saving time, remsa Health, in partnership with the Washoe County Health District, donated LED flashing lights, armbands, and lanyards to community groups to increase awareness about pedestrian safety, especially as there are more hours of darkness through winter. Executive Director Adam Hines provided interviews to Colo and KRNV last week when temperatures fell. He advised about ways to stay warm and safe during winter weather. And as a private nonprofit organization in the community, it is important for remsa Health to support other nonprofit organizations. Two recent examples of that include our support of KTVN's Share Your Christmas Drive-By Food Drive event last Friday, during which remsa Health made a generous donation of cash and food.
And earlier this week, a crew decorated their ambulance and delivered some holiday cheer in the form of cupcakes to the residents at Eddy House. And then finally, I would like to share with you an important project that has been under development for a few months. Through a partnership with Washoe County Health District, remsa Health has put the finishing touches on an explainer video intended to help the public understand that the 911 call is changing, and that's okay. A full distribution and promotion plan for the video will be launched after the new year, and we have the video to show you today. Oh, there should be sound.
Do you want me to try?
When it matters most. Over the years, we've learned that helping people receive the right level of care is really important to our community. And because the 911 call is changing, the way we care for you is changing too. This might surprise you, but more than 30% of the calls that remsa Health responds to are for first aid level care. That means we're sending ambulances for things like sprained ankles, sore throats, and toothaches, which takes away vital resources for serious emergencies like strokes, heart attacks, severe allergic reactions, and major injuries. remsa Health is focused on reducing the unnecessary use of emergency transport services by offering alternative options when a medical dispatcher or ambulance responds to your 911 call. A remsa Health medical dispatcher will listen to your needs and offer the care that's right for your situation. Our medically trained dispatchers may tell you that instead of sending an ambulance, they are going to transfer your call to a registered nurse in our dispatch center. Or responders may tell you that you can get the care you need at home through a telehealth virtual visit. They may also suggest transporting you to an urgent care facility for treatment rather than the emergency room. All of these are safe, convenient, and appropriate ways to be evaluated and treated, either entirely at home or in an urgent care location, which frees up resources for emergencies in our community and doesn't result in a visit to the ER, which can be expensive or lengthy for you. Just provide your medical insurance information so we can connect you to the right care resource. So don't be surprised if a remsa Health medical dispatcher or the paramedic or EMT at your location offers you these alternative care options. You may not always end up in the emergency room from a medical 911 call, and that's okay. By using the care option that matches your medical need, you're allowing resources to be available for those who truly need the highest level of emergency care. And you're actually helping us save lives.
I'm happy to answer any questions you might have about the public relations report.
I have one question.
Sure.
Where is that going to play? Are you just put on TV? Is that going on web? Because that's fantastic. Good news.
Thank you. And as an aside, it took a whole creative team to put that together, so I will pass along your comments to them as well. Yes, so we are planning a full promotion campaign after the new year. We'll include this on our social media. It'll be sent out to our e-newsletter subscribers. We'll be sharing it with all of you to share and post as well, of course. It will also be housed on our website. It's there now under the blog section. We also have a vanity URL that is in development right now called Choose the Right Care. Hopefully by the next time we meet, that will be launched and I can share that with you as well. The idea there being kind of a choose your own adventure in terms of finding the right care pathway. So this video will live there as well. So we plan a full promotion around it.
Somewhat of a silly question, but I'm assuming this is all going to be in Spanish as well?
It is, yes.
Great.
Yep.
Cool. Thank you. Further comments? Seeing none, we'll accept your report. Thank you.
Thank you.
Item 9D. And my apologies, Mr. Abbott, for calling Mr. Hines. Well, my apologies. Gotcha. Mr. Dow.
This action item, or not action item, but item goes back to a meeting a couple of months ago in relation to the conversation to the board was what type of enhancements, further enhancements could be done to the pre-hospital care system in our community to help patient navigation and population health efforts. Again, sort of targeted, as you saw on the video, towards the idea of getting the right level of provider to the right person at the right time, and then helping and guiding that person into the right clinical pathways through our health system, and not always just going to the emergency department. So in that discussion, part of that was the concept of assess and refer, and developing that enhancement for our community. So with that, I'm going to turn it over to Adam Hines. I will say that it was asked in the development of this 2 months ago to make sure that this was a unified effort, and I will say that as many of you know, this has been a lot of work, not only in our organization, but our co-response partners and also the hospitals have all come together over the last 2 months to look at this enhancement, to develop the protocols, approve the protocols, and the processes involved. So with that, I'll turn it over to Adam.
Thank you, Mr. Dow. Good afternoon. Adam Hines, Executive Director of Integrated Healthcare. So an appropriate time, obviously definitely complementary to the conversation that we're having today, is the need for us to progress the way we manage patients. You know, as of today, and actually I want to make sure to highlight that what we're doing here in Washoe County, many communities aren't doing. The idea of having a nurse health line safely triage you out of the 911 system. You know, last month there were 90 patients that were safely triaged out of the 911 system. That doesn't seem like a lot, but when each call takes an hour, you know, that's 90 hours that are back, you know, injected into the emergency system for potential an emergency. When our care providers arrive on scene and they have the ability to navigate somebody, whether using our partner agency to do telehealth or to an urgent care, you know, it's the most appropriate level of care for the right patient at the right time, and there's many places that aren't doing it. But as of today, really, there are two options. You know, we can take them to urgent care, which may be appropriate, but they're not always open, may not necessarily always be aligned with the patient's insurance, and it may not be where they want to receive care. And so we only have the option of transporting them or them refusing care. And so this is really the opportunity for us as we talk about, you know, at least 30% of the calls in which we receive either no care because it's not indicated or first aid level care. These are the patients in which would qualify for this protocol. And so we're calling it assess and refer. And essentially it allows for those paramedics when they get on scene. You know, previously we could not tell somebody, you don't need an ambulance. The question was, where would you like to be seen? And so we have identified through different stakeholder groups, through different processes, and as well as different model protocols, identify different complaints in which we believe are safe, we believe have a low potential for repatriation, and obviously the low potential for there to be a serious underlying medical emergency, and allow the providers when they arrive on scene to essentially tell the patient, based on what you're telling me, based on your physiologic exam, you don't necessarily need an ambulance. You may need to seek care, but you don't need an emergency ambulance. I think important, there's a nuance there that we're not refusing to take somebody to the hospital. We are essentially suggesting, because many people at 2 o'clock in the morning, we don't expect them to be doctors. They may believe that they are experiencing a medical emergency, and after careful exam, we find that that's not the case, and we can navigate their care. And so really that's the purpose of this protocol. A little bit about how we got here, A lot of the basis of this is the protocol in which we have used, or at least the clinical presentations and the physiologic parameters are based on the patients in which we have either referred to telehealth or have transported to the urgent care. And the reason why we use that as a foundation is because we've been monitoring those outcomes like a hawk. Every patient that gets transported to an urgent care or gets referred to telehealth, we review for a couple things. Number one, did it meet the clinical criteria, which we have high compliance? And when there's high compliance with protocol, there's low repatriation, essentially meaning that the ambulance has to go back because of an emergency. So that really has built a lot of comfort. In addition, there's been a lot of consultation, not only with our medical directors, but also medical directors of the urgent cares. There are other protocols that are out there. You know, there's not a lot of path for us to follow because we are progressing this here in this community, which I think we should be proud of, because the idea in which, you know, you call and we haul is an unsustainable 30-year-old model that we have to change. And so we're very appreciative of the support of the board to be able to do this. This was accepted at the JAC, which is a meeting with myself and Executive Director Abbott, as well as the fire service partners. So they have the ability to review this, provide input. So that's Truckee Meadows Fire Protection, or Fire Rescue, Reno Fire, Sparks Fire. And that was accepted on the 10th of November, as well as all of the agency medical directors had the ability to weigh in, and then finally the fire service chiefs. So as Mr. Dow indicated, we believe that this has really been looked at holistically. We believe that this is something in which the entire region should adopt and will be available for them to do so. All of our crew members have gone through training, which included our medical director, Dr. Jenny Wilson. And unless the board has any concerns or questions or reservations, it's our intention to move forward at the first of the year with this.
Questions or comments? Councilman Dare?
Yeah, so we start January 1, let's say. Does that mean we start educating January 1 or we start implementing January 1? Because sometimes it'd be nice to somehow educate what we're about to do before we do it. So what's your thought on that and what's your plan?
Thank you for the question, Councilman Dare. We have had the opportunity in the month of November to go through all of our crews and train them. We've made that offer available to the fire service to be able to share that training. Like I said, that did include Dr. Wilson. And then what we will do is obviously publish this protocol. There's a ton of familiarity with it because it already exists in some form, which is the transport to urgent care and transport or eligibility to telehealth. So the clinical components of it is going to be very comfortable to our team members because they're already assessing patients for eligibility. I think important, obviously, is a communication to our community, and I think that's what Alexia is really working on. There is, and I think in the packet you saw, there is a piece of collateral that's left with the patient that does a couple things. Number one, it makes sure that they are consented to understand that based on their presentation, they don't necessarily need an ambulance. They may need to still seek care. And then what do I do with that, right? Some people, the reason why they're calling an ambulance is because they have no idea what to do. And so it's our job to help navigate them. And so the front page kind of tells them what their condition is, allows us to document some of those physical findings. And then the back page is a resource. It's obviously not exhaustive of everything in our community, but it is a resource guide so that we can begin to navigate them to those points. That is available in English and Spanish. And then finally, within 24 hours, these individuals will be called by our nurse helpline, and they will just check up on them and say, are you doing? Has your condition worsened or changed? Did you follow up with our care? And really allow for us to get better data points so we understand, is this effective?
Thank you. So you know that's not in my packet. I don't know if that was supposed to be. I just want you to know what I got. I also get my stuff about a week ahead of time. So
it was in the updated.
So if somebody can get me one of those,
I would be happy to send it to you, and if the board wishes.
So when I talk about education, I appreciate what you just did. And I actually want to say I'm pleased with the process and what we've gone through. I mean, all that stuff. The only piece of process that I think I don't think we put out this information out to our community yet. So my only concern, thank you. One of my only concerns would be that we're moving forward and trying to educate at the same time we're going to have some frustrated people who don't understand. We might get that anyway, but in principle and due diligence of us, it'd be wise. So I don't know, or have we start communicating? I've not seen anything out there yet on TV or anything like that of this message. So if it's been out there, maybe I've missed it. But if we've not, I have a little bit of a just pause, and it's probably like a 2-week pause to say, it'd be wiser for us to communicate to our community this is coming than us start it and say, hey, we're going to communicate at the same time, is my opinion.
I appreciate that. And I will tell you specifically, this has obviously not been communicated to the community because we're not comfortable, obviously, telling them something's going to move forward if it's not going to. I can assure you with certainty, because I have the privilege of doing a lot of the media interviews for the organization, that our message has been and will continue that we have to expect different care navigation pathways when you call 911. And so that may mean you don't necessarily get a paramedic ambulance. You may be able to be treated from the comfort of your home with telehealth. So I think we're working to tee that up, but I think your comment is something in which we can take back and make sure that whatever those medians are, like you said, we're not going to obviously be able to reach 100% of people, but if we are able to do that, then I think that that's appropriate.
I just want to be surprised, so I want to make sure I clarify. So will you guys look at the idea of communicating before implementing?
Yep.
Okay,
Yeah.
that's not what I heard first, so I just want to make sure that.
Yeah, and I'd be happy to share with you some of those ways that we intend to do that over
I know,
the next couple weeks.
and we want to help. I tell you, the city council, I know all of us, we want to help in every way we can. So it's not that it's like, hey, it's your job to do this. It's our job. I get it. But I would hate for everything January 1 to begin and then everyone's, okay, thank you.
Yep.
Thank you for those questions, Councilman. Along those lines, I know you guys were originally supposed to meet with the EMS Advisory Board. Is that correct?
Yes.
And did that meeting take place?
So the last EMS Advisory Board was canceled and I think is not until next month?
The March stands out to me that they weren't going to be available until March. So I think the plan was that we would come back to you folks. I do think there's a communication that was being sent from the EMS oversight group. I don't think anybody is here to speak to that.
I think Andrea is.
But I don't know if Andrea Esp can help clarify.
Sure. Mr.
That.
Kevin Dick?
Yeah, they're correct. The EMS Advisory Board meeting was canceled. I think it's February is when it's scheduled for. But there was a meeting that Manager Brown organized on last Friday afternoon that the fire chiefs each attended. The hospital CEOs of Renown and St. Mary's. Helen Littleman wasn't able to attend from Northern Nevada Medical Center, but Shelby Hunt attended on her behalf. So we had them participating, Mr. Dow, city and county managers as well. And we discussed this, and there was unanimous agreement from everybody to move this to the District Board of Health for consideration today.
Okay. Thank you for that clarity. Yeah, it was important for me to make sure that everyone was on point with this, so I appreciate the outreach, even if you guys weren't able to have the meeting. That was really the intent, so it sounds like everybody was at the table. And Mr. Hines, I should call you Mr. Abbott, right, just to pay back? Yeah. Mr. Hines, it was, my understanding in terms of what you provided is that you guys will, once daylighted after communicating with the community first, then the delivery aspect of it, is that the measurements will be then submitted to us in terms of how often it was used, geography and so forth, so we're all kind of aware in terms of where those assessment referrals took place.
Absolutely. My intention initially was for us to be able to have that presentation at EMS Advisory Board, but if it's the wish of this board, I mean, it would be something that we would be able to do with some sort of frequency to let you know. Utilization, repatriation, you know, I think some of the clinical complaints that Dr. Danko brought up about the CARES campus, I think is important for us to look, and is something that we're looking at. I'm unfortunately just not prepared to be able to provide that with confidence today. But those are definitely a lot of the drivers for us. I mean, we want to obviously, just as the District Board of Health wants to ensure that every patient receives high-quality, compassionate, clinically excellent care. We know that there are patients in which we do that every single day, and the fire service does as well. But we also know there's a large portion that can be navigated safely through a different means. And we want to make sure that that piece of the pie we're slowly and appropriately and safely cutting out to make sure resources are available for emergencies.
I think it's, yeah, it'd be great to have that information. I think as someone that could also go back into our jurisdictions and say, you know, there's a ton of time being spent, for example, at the CARES campus, and they're not necessarily being transported. It's all being taken care of there, but it's taking tons of time and energy. And so how are we getting back to the CHAB board, et cetera? So great. Further comments, questions? Seeing none, that's an action item.
I'd move to approve.
I have a motion. A second. Any public comment? I'm sorry, Susie.
No public comment.
See no further discussion? All in favor?
Aye.
Any opposed? Motion carries unanimously. Thank you, Mr. Hines. Merry Christmas. Item 10, a public hearing. I'll share language for this. Has everyone received the proper communications with respect to opening the public hearing? Yes? Okay. We'll open the public hearing. Mr. Franklin.
Good afternoon, Mr. Chair and members of the board. My name is Luke Franklin. I'm a senior REHS of the Environmental Health Services. With me today is my supervisor, Mr. Wes Rubio. We're here to present information to support the possible adoption of the business impact statement regarding Washoe County Health District permitting and fees for regulated underground storage tank facilities. Staff report was included in your board packet, which includes a summary of potential impacts. It should be noted that at the time of the submittal of your packet, we didn't have much interaction with petroleum industry, but we have in the recent weeks. All existing UST facility owners and operators were notified with a postcard, mailer, and via email with information on how to access the proposed regulation in public workshops. During the public workshops, the proposed permits and fee were discussed and reviewed in full. All workshops were made available through Zoom, and the meetings were only attended by people on Zoom. The petroleum industry was engaged early in the discussion and made aware of our proposed fees. There was some concern that fees could impact some local facilities that do not operate or have other locations in areas where permitting already exists. However, maintaining these services with the local jurisdiction was favorable compared to state oversight. The proposed fee is equal to or less than neighboring counties and states where information was publicly available. And the proposed permitting and fees will allow Washoe County to follow previous District Board of Health direction, and by using the additional funding from NDEP to keep the proposed fee at a level that minimizes the impact at existing UST facilities. Therefore, the Washoe County Health District Environmental Health Services recommends the District Board of Health adopt the business impact statements provided, and I'm available to answer any questions from the board or to clarify anything that you guys have regarding it.
Thank you, Mr. Franklin. Yes.
Just for clarity, this is Wes Rubio. This is actually for the adoption of the public hearing. So this is the actual public hearing that we're doing. The business impact statement was previously approved in October of the District Board of Health.
Correct. I remember that. This is actually the adoption they originally introduced back in October, where we approved the original introduction. Now this is adoption. Prior to, if you guys wouldn't mind, board, if I'd like to take public comment first before we move into discussion.
Yes, we have Mr. Peter Kruger for this item.
I'm assuming that's on. Good afternoon, Chairman Delgado, Director Dick, members of the board. I'm Peter Kruger. I'm the State Executive of the Nevada saying that these individuals are really a credit to the district health system. I want to begin by saying that we're not here to outright oppose a fee increase. And as I go through the documents you have, I'm not going to read it to you. It's there for your understanding. I want to highlight several points. We feel that while the district health office department nor a private business can operate at a loss for very long, we aren't opposed to a reasonable fee increase or to recreate the UST program at the Washoe County level. And as I think Mr. Franklin indicated here, in support of keeping this program at the local level, like the old adage goes, it's the best governance at the local level. So we are supportive of that. I want to begin by highlighting, I think, a very common misconception that, and maybe some of you have this misconception, that is, as motorists and citizens travel on our roadways and are in our community, they see service station signs that might say Shell or Arco or Sinclair, any of the major oil companies. And the thought probably for many is that, oh, those stations are owned and operated by those multinational big corporations. In Nevada and Washoe County for sure, no retail gas station is owned or operated by a major oil company. The individuals that own those stations are, in many cases, small business people, and typically, in our community, new Americans. So, for people to believe that raising a fee on a big multinational corporation is without pain, this is not the case here. Right to it, we have proposed, and we're very much upfront with the gentleman to my left, we believe in, that we, do I only get 3 minutes? Yes. Well, I hope you'll consider our proposal. Thank you.
Thank you, Mr. Gruber. Any questions for our staff, for our team regarding item 10?
I have a couple thoughts, and
Yeah.
so I know we've had a lot of public comment on this, but I do want to remind, I think it's important that we do look at this, that this is, even in conversation, this is the public hearing, so this is where people get to bring stuff. So I don't know, I know you guys have been meeting, and I don't know, it sounds like from what I've heard, this is the first we've heard of what I have here. So it would have been nice to get that sooner, but this is the public hearing. I want to remind all of us that that's important and procedural, that we look at that though it's nice to get information ahead of time, this is the place we get to make conversation. With that said, one of my goals from the beginning, and I think we talked about this, is are we working with everybody to make sure that what's the best answer, all these things. I think I read through this before I got here quickly. My question is, and I probably would be more comfortable trying to find a way to make sure we can work with our state and our thing than just making a decision today for me. And the reason why I say that is I question if 1 month of us sitting down and talking about this, I'm not saying this is the right answer. I don't know because it came in late, but I appreciate what our state does and what Peter Kruger does and things, and I'm just questioning of us just pushing forward. It actually asked some of the questions I asked from the beginning. I don't like going from no charge to $875. I mean, that to the large charge. I questioned if we could do it in increments, and then what came back to me in our conversation, if I remember right, was, oh no, we put this out to everybody, they're okay with it. We didn't have anybody come back with anything else. And that was true. I think it was right, what you said. But now I do, which makes me have to pause and say, okay, let's talk about this and make sure if there's a way to, if doing increments is a good idea. I don't know, or not. But this was a question I think I had when we started, and now it's come back. So I'm gonna I'm going to have to say, I'd rather pause this, have a bigger conversation, make sure what's right, than just say no from me. So that would be my choice. It would be what I would ask. And so I know that's different than was expected, but I didn't expect to get this today. So that's my approach.
Thank you, Councilman. Any further comments from the board? Quick question for the team here, and I believe I asked this last time around. This is really an opportunity for us also to move forward to receive a grant. Is that correct?
Yes, Joe.
Your mic's off, I think.
Oh,
There you go.
there it goes. Wouldn't light up. Yes, Chair Delgado, that is correct. So if, with the grant from, or for lack of a better term, grant contract with NDEP, this is what enables us to actually have a lower fee. If we don't have the grant and we were to institute this without that, then the fee would be higher, or we would no longer be able to support those actions with staffing resources here at the Washoe County Health District, which also means that we would then, in addition to that, no longer be able to perform some of those other actions that we currently do and receive fees for, which would be the plan review of new UST sites being constructed, inspected on install, and UST tank removal. So we would no longer be able to conduct the oversight or remediation activities that would be associated with the removal of those tanks. Because we would no longer also be extended the authority under NDEP to do those actions. So those would all go to the state. And as the state did state to us and has stated to the petroleum industry, if this does go back, it does mean that they will institute fees statewide sooner. They are already looking at instituting fees statewide because the state was reduced by 50% their EPA funding to implement their own program, which hence caused the reduction in our funding. And so we are currently, with the proposed funding that you see before you, we will be matched with Southern Nevada, which has also had permit fees in their jurisdiction for over 20 years. And they are also looking at rectifying their 20-year-old fee.
So again, we're running at a loss in terms of providing salaries for a lot of our team to go and conduct inspections. This is an opportunity for us to go and raise the fees in order to support our team to conduct inspections now and moving forward.
That's correct.
And if we did not want to utilize the NDEP funds, or what I'm seeing in the staff report, fees can be as much as $1,334. What the grant is, what the NDEP support will actually lower the cost to $875, which will allow for our team to conduct inspections and moving forward also, and not in the present and in the future. Is that correct?
Yes, sir. That's the intent.
Okay. And then you guys have done outreach, worked with a lot of folks already. You guys have done all the public hearings, et cetera, et cetera. And today we have a public comment that there's an individual that's not supportive of that.
Yes, yes, sir. Every facility received a postcard. So every facility that we have, regardless if it was owned by one person or one person owned 16, that one person received 16 postcards. Every email that we could get, and Mr. Franklin here to my right physically contacted people who we didn't have emails for and reached out, received an email, and were offered the opportunity to attend. All meetings were available for people in person. We had no one attend in person. All meetings were held via Zoom, in which we had 2 industry people attend by Zoom, and all 3 meetings were attended by the group that also spoke today.
Thank you, Mr. Rubio. Mr. Franklin, any further comment from the board?
I have one question, because I appreciate that there's a grant attached to this. Is there a timing on this grant that says, I mean, is this a 2021 grant and we're going to lose something? I mean, it's important to know. That's part of this process is some of the timing, because I'm not questioning that we have a wrong answer. I'm questioning if there's a push and a quick thing to this. So are we on a time crunch here?
Yes, for implementation, yes, we would be on a time crunch. The grant would need to be, if this is approved today, then we would be able to initiate work for the first half of the year for 2022. And then the grant, we would receive $50,000 for the first half of the year. After that, the grant is $100,000 per fiscal year going into 2024 or 2025.
So if it's not approved today, we lose that grant. Is that what you're saying?
If it's not approved today, we cannot move forward until we can identify how we would sustain the program.
But if we just, for sake of hypothetical, so next month we come together and we look at this and we vote and we move forward, would that grant still be in place?
No.
That's my question.
We
Thank
would
you.
likely have to move that on to the next Board of Examiners meeting with the state. We'd probably be looking at some time in the neighborhood of April, I believe, based off of the way the state's due dates are. And likely we would not be able to finish the work in time to actually utilize the grant monies for the first half of the year. We would
Thank
make
you.
every attempt that we could.
That's the question. Thank you.
Yes, Mr. Kevin Dickoff.
Yeah, if I could just add, Mr. Rubio actually came to me to make sure I could sign the agreement today if it's approved, so that, or it was approved, so that it can get to the Board of Examiners meeting. We're up against the deadline for that now, which is why then it's such a long time period to the next one. And then I also just wanted to add that the staff really sharpened their pencils and looked at what it would cost to implement this program. And so they were able to identify some efficiencies and reduce the staffing requirement on this from what we previously had at 1.6 FTEs down to 1.1. So they were, being fiscally responsible and trying to minimize cost burden to industry and how they approach this.
Public comment, Susie, on this item?
No, Chair, but for the record, the document you received just now was just given to us by Mr. Kruger and will be placed on the record.
Okay, thank you very much. Any further comments from the board for our team? Seeing none, I'll be interested in a motion, please.
I move to adopt the Washoe County Health District permitting and fees for underground storage tank facilities beginning January 3rd of 2022, with all facilities permitted no later than January 29th of 22.
I second it.
A motion second for the discussion.
I just want to say, I'll support this, and I'd say this, that my ultimate goal always is collaboration where we can. And so I appreciate all the work you've done. I don't think it's ever bad to slow down. I don't want to lose our grant money. That's obviously essential to what we're doing and makes sense to this. So to anybody out there that I hope they understand that, but I just tell you, for me, that's that. So thank you.
Thank you for the questions, comments, Councilman. All in favor, say aye. Aye. Any opposed? Motion carries unanimously. We've been sitting down for about 2 hours. I'd ask our board just take a quick 5-minute break. And then
Chair, I'm
Yes.
sorry to interrupt. Oh, wow. Hello. Will you please close the hearing?
Yeah, I'll move to close the hearing.
Thank you.
All right. Quick 5-minute break. Thank you.
member. And with that, I'm going to ask Mr. Vega to come up and give an overview and guidance on this number 11.
Thank you, Mr. Brown, members of the board. For the record, Francisco Vega, Director of the Air Quality Management Division. I think a lot of the information for this agenda item has been included in your packet, but I would like to highlight a few things because this is kind of a new process that we are doing. So let me begin by stating some background on the Air Pollution Control Hearing Board. The Air Pollution Control Hearing Board is established by Nevada Revised Statute. Our regulations allow it to consider appeals of actions taken by the Air Quality Management Division and petitions for variances. The board consists of 7 members who are not employees of the state or any of its political subdivisions. The membership is required to include 1 attorney, 1 professional engineer registered in Nevada, 1 licensed Nevada general contractor or engineer, and 4 at-large appointees. And then the terms can be from 1 to 3 years, with any kind of succeeding term being for 3 years. So at this point, just to kind of let you know where we stand at right now, we currently have 3 active members, so we actually do not have a quorum currently for the Air Pollution Control Hearing Board. Next, I'd like to discuss kind of what we did to try to recruit for applicants for the board. So back in September, in response and feedback from the District Board of Health, the division issued a press release soliciting members of the community to apply to participate on the board. The press release was posted on the website, and it was actually also sent out to thousands of email addresses. We've got a email subscription list for anybody interested in air quality items, and that thing, I think that list has about 1,000 members. And then we also have a health district email list, which much more members on it. And again, this press release was sent out to all those email addresses. Lastly, it was also shared on social media such as Facebook and Twitter. I'll mention that the press release remains on the AQMD website, and we will continue to accept applications indefinitely. With all of that work, we received a total of 17 applications for consideration to join the board. 1 for the attorney position, 2 professional engineers, and then 14 for the at-large positions. All applications were reviewed, and interviews were conducted with at-large applicants to be considered further. Appointment recommendations are based on ensuring the board is able to cover certain areas of subject matter expertise, and recommendations on the terms are to ensure not everyone's terms expire at the same time. So for example, right now, all of their terms are expiring within the last like 5 or 6 months. So the recommendation on the terms, again, we're making it so they're staggered, so not everybody expires at the same time. And lastly, I'd just like to clarify that while the division is making recommendations, the board may consider all applicants for the positions. And with that, I'd be more than happy to answer any questions.
Well, any questions for Mr. Vega?
I have a comment.
Councilman Taylor.
I just want to say good job. This is one of the things we asked for, is making sure that we have these boards and that they transition. And so thank you for the work you've done on this. Appreciate it.
Any other questions or comments from board members? Do we have a motion?
So moved, please.
Second.
We have a motion, we have a second. All in favor, signify by saying aye. Aye.
Aye.
Motion passes.
Aye.
Do you need us to read that? Recommend with the names?
Okay, for the record, it would be helpful if the motion does include the name of the person being appointed. Yes, please.
It's right here.
So John, I believe the motion you want to make is move to appoint Mr. Anthony Dimple to the Nevada Registered Professional Engineer position on the Air Pollution Control Hearing Board for a 2-year term beginning in December 16 of 2021 and concluding December 15 of 2023. Is that correct?
Thank you. That's what I meant to say.
Okay.
I'm with him.
Okay. Do we need to agree on that, or are we okay with that?
I think that clarified for the record.
Okay.
Thank you. But going forward with item 12, we'll follow that.
Okay, sounds good. Mr. Vega, item number 12 is yours too. Thanks for staying up there.
Perfect. So for the last agenda item, we discussed the registered professional engineer position on the board. With this agenda item, we are looking at the at-large positions. So I believe it's 4 positions that we are recommending. And Everything I stated in the previous agenda item still stands. All the work we put into it is exactly the same. And again, I just mentioned that while we are making recommendations, the board can choose any of the applicants.
Good deal. Councilman Darrett, looks like you have a
I'm
comment.
happy to make a motion. The board may consider, let's see here, possible motion. I move to reappoint Mrs. Yvonne Downs for a 3-year term beginning December 16, 2021, and concluding on December 15, 2024. Reappoint Mr. Lee Squire for a 3-year term beginning on December 16, 2021, and concluding on December 15, 2024. To appoint Mr. Phil Schweber for a 2-year term beginning on December 16, 2021, and concluding on December 15, 2023. To appoint Mr. Martin Breitmeyer for a 1-year term beginning on January 27, 2022, and concluding on January 26, 2023, to the Air Pollution Control Hearing Board.
I second what he said.
Okay, so we got a first and a second. All in favor signify by saying aye.
Aye.
Aye. Okay, motion carries. Mr. Vega, thank you very much.
Thank you very much.
All right, moving on to item number 13, presentation and possible acceptance of the 22-24 strategic plan. And Ms. Ratty.
Hello. My name is Julie Reddy, Director of Programs and Projects for the record, and I'm here today to present the 2022-2024 Washoe County Health District Strategic Plan. It feels like it wasn't all that long ago that we spent a number of hours together in a room going through this in pretty extensive detail, so it's my intent to move through this relatively quickly because you all participated in that retreat, wanting to make sure that we get it on the record. If there's any place that you want to stop, just wave and I will slow down for you. So this time this is how we planned this particular cycle. We did a refresh and not an overhaul, meaning that the core elements of the plan, when you talk about vision statements, mission statements, and priority areas for the health district still stood, and we worked at the level that was down below that at the goals, outcomes, and initiatives level. We built from the middle out, meaning that we sought quite a bit of input from our team members at the health district that work in all levels of the organization, and then push that organization out, or that information out throughout the organization. We worked with On Strategy, and On Strategy interviewed board members to get their critical inputs, and then we braided together multiple efforts. And this was a result of much of our planning work was halted during the COVID response. And so to get us back on track, we worked simultaneously on our strategic planning, on our workforce development planning, and our setup for our performance management system. As you all remember, we had a retreat on November 18th, and during that retreat, we did an update on our public health sector trends and community health trends. We refreshed the strategic plan priorities and goals based on those community trends, and we included learnings from the pandemic response. And we had discussion on the appropriate future investment of resources in the health district and the community. So we talked about what the budget impact would be and what the investments might look like in the budget process. Our wonderful team out of our EPHP division did a presentation on community health trends, and they talked about the needs that have been identified in prior community health assessments, and that really those community needs have not shifted in the post-pandemic landscape. That global pandemic has, however, magnified some systemic issues which already existed. And in the US, the pandemic proved the nation's inability to prevent detrimental health outcomes among the most marginalized populations. So we've really learned many lessons from the pandemic response, but the needs themselves haven't changed significantly. We also talked about public health trends. Not surprisingly, public health is on the news and in conversations more than it probably ever has been before. In those trends, what we're seeing is that there are increased public health challenges. Those include climate change disasters, pandemics, and increasing population health challenges. There's increasing demands for data requested by folks like you and the community at large who want to know more about what it is that we're doing and what kinds of impacts we're making. There have been disparate health outcomes resulting from your income level, your education status, your neighborhood. So we know that public health is not affecting everybody equally. We know that there's a needed transformation in public health funding. We had a lot of conversation about how a lot of the funding that comes into public health is designated to certain things, but we don't have a lot of broad-based funding to be able to be strategic and work on important initiatives. and that we have an insufficient workforce to meet basic public health needs. So that was the public health trends summary. Again, to the core elements of the plan, we did not make any significant changes to vision or mission. We did not make any changes to the strategic direction or our value statements around trustworthiness, professionalism, partnership, and collaboration. And that is where we're saying that it is a refresh. That is the work that we'll dive into next year when we do a full update of the strategic plan. On the priorities, we started with priority number 1, which is healthy lives. And in this area, I would like to ask for one modest amendment to the plan that was provided to you in advance. That's primarily an oversight. We would like to add goal 1.3.3. It would be on page 6 of the strategic plan that you have in your document. So there will be 1.3.1 and 1.3.2 will exist. We'd like to add another one, which is 1.3.3. The language for that goal is to provide efficient, effective, and culturally sensitive services. And it was an oversight of a bucket of work that we were missing that primarily comes out of our Clinical and Community Health Services division. That is primarily work that is done around access to care. So some examples of initiatives that might fall into that bucket would be our telemedicine initiatives, some of the work that we're doing to make our services more culturally sensitive, 5 days a week, same day appointments, that kind of work around accessibility. So when we get to the point of making a motion, I can repeat that again, but we're hoping to add 1.3.3 into the Healthy Lives priority. Moving on to priority 2, the healthy environment. This was perhaps the topic that had the most discussion in the retreat, with some specific emphasis on waste management and recycling. We did make a modification to the goal around recycling within the strategic plan based on input from that retreat. This is represented in your packet, so it does not need to be addressed in the motion, but I just wanted to highlight it because it was a change that was requested coming out of the retreat. That goal now reads, coordinate with state and local partners on waste reduction education, diversion education, and proper disposal. So it expands that role not just to be how do we get rid of waste, but how do we make sure that we're working with all of our partners on all the different ways around education, diversion, and disposal. Moving on to, that was priority 2, healthy environment. Moving on to priority 3, that's our local culture of health work that includes our communications efforts, our research and data sharing efforts, and our public affairs and government affairs efforts. On to number 4, those are the impactful partnerships. We know at the health district we can't get everything done ourselves, and it's an important thing that we do is work with our community partners. Moving on to 5, that's our organizational capacity. A lot of conversation around this particular priority, around significant work that we need to do around workforce development, investment in additional services. How do we lift up our technology efforts? All of the strains that we have seen here at the Health District around our capacity to deliver services when we've been working in a cost control environment for quite some time and have learned the hard way that sometimes we need to surge, and how do we really do some thoughtful work around that? No changes to the plan, just lots of discussion there. And then finally, priority number 6, which is financial stability, making sure that we have both the investments and the good governance to make sure that we're taking care of the taxpayers' money. So those are the 6 priorities. Talking about moving from planning to action. So we have our strategic priorities. We base those strategic priorities around community indicators. So those were the data that were presented by the team around all of the health indicators in the community and what motivates us to work on the kinds of things that we do work on. From those community indicators, we developed goals that were presented to you and are included in the strategic plan. And that's sort of where the strategic plan ends. And then we move into the action plan for staff, which includes performance outcomes. Those will be measurable outcomes so we can determine how we are making progress. That's part of the action plan. And initiatives, what is the actual work that we're going to do? So what you're voting on today are the first 3 bullets. At the staff and management level, we have the work around performance outcomes and initiatives, and we will be reporting back to you on all of it. But the governance role is the overarching strategic plan. At the staff and leadership role, it is the performance outcomes and initiatives and getting the work done to meet those goals. As next steps, we are working to complete the workforce development plan. It's a sister plan to this plan and is part of our FAB requirements. We are re-engaging with our performance management system. We have a contract with ClearPoint. It's a data management system around performance outcomes. So we're going to take all of this information, put it into the plan, and hopefully start spitting out some beautiful reports for you to review at future agendas. And we're going to develop some scorecards and dashboards to report out on progress. We really do hope for those to be meaningful tools at all levels within the organization for how we're doing against the plans that we've set for ourselves as an organization. So those are our next steps. With that, I'll just stop and see if you have any questions.
Councilman Dare.
I have a comment. I want to say I really enjoyed the whole process, actually, what we were involved with. I know there's a lot more that you guys all did with this. It has nothing to do with us, but good job, and I really appreciate it. I look forward to seeing these reports, and I think this is the best way we can do our job of making sure we're helping our community, especially making sure that we are holding ourselves accountable to goals and making sure that's all there. So wonderful job, and thank you.
Thank you.
I got to say, echo Councilman Dare, and I know for our Chairman Delgado, our event in November was, thank you. It was neat to see how the process went. You made it painless for all of us. And I got to say, the interaction with the employees was great, especially how you spread us out throughout the entire program so we can interact with them and see what exactly was going on and hear what was going on. So thank you very much.
You're welcome.
Any other comments? With that, do we have a motion to accept?
Before we jump to motion, I'm sorry, I did have one more comment. I would be remiss to not thank Erica Olson from On Strategy, who helped to facilitate the entire project, and the division directors and Kevin and the leadership team that put a lot of work into creating the plan, and that next level within the organization, supervisors who really, most of the work comes from that supervisor level where it's their programs, they're the subject matter experts, they know what they're doing in those areas. And then we had the real privilege of doing retreats where many of the staff members got to participate. And so just all hands on deck on this one, and just want to say, extend my gratitude to the team.
Good deal, thank you.
I move to approve the FY 22-24 strategic plan.
May I add
Council,
a suggestion
yes,
on
thank
the
you.
1.3.3?
Oh, yeah, 1.3.3 added in there. Thank you.
Do we have a second? We have a second. All in favor signify by saying aye.
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 Motion carries. Thank you, Mr. Addy. Really
Thank you.
appreciate that. All right, moving on to item number 14, recommendation to review and approve the district health officer's annual performance evaluation results. And it looks like Ms. Griffey will be coming up. I think it shut off. There you go.
There we go. For the record, Lori Griffey, the HR rep for the Health District. Mr. Dick's annual evaluation was distributed to the board and to other participants on Monday, September 27th. We had 40 participants that the board had approved to participate in this event. 2 reminders were sent to encourage participation. The evaluation closed on October 8th, and the district health officer's evaluation results are all in your packet. Excuse me. 35 out of the 40 invited participants completed the evaluation. This was the highest participation we've ever had. We had 87.5% participation rate. Let's see. Each survey had a specific question that said, select the best statement for the overall evaluation of the district health officer. And 92.06% of the participants rated the district health officer as meets or exceeds expectations. And then we went on with all the rest of the questions. The overall for all the questions came up with an 88.75% that Mr. Dick met or exceeded expectations of the people who participated in the evaluations. We did have 11.25 rate them as areas for growth, and several put notes in there of areas that might be addressed in the future. All the comments from the evaluations were included in your packet, so you can review those. Our recommendation is that the board accept the evaluation as presented, and the board can discuss the review and provide guidance to Mr. Dick on any possible goals or areas you would like him to work on in the coming year.
Thank you, Mrs. Griffey. So with that, I know that our health officer has been through the packet, and as well as the folks that are here today. And do we have any comments for the health officer anybody would like to make as far as the packet itself?
So first and foremost, I do want to say what an incredible, amazing time to be a health officer. And I mean that. This is one of those things that there's nothing easy about a lot of our jobs in this particular moment. And I've had the honor of being on this board almost 6 years now, actually. And with that said, this is obviously some of the most tumultuous times we've had of trying to face things. But I think in many ways we faced it very, very well. So I can say this. I'm one that I want to say that I'd say 90% of the time, which is actually not bad if you think of most relationships, that's good. There's a few things that I've always been concerned about, or at least the last couple of years. These are things that we've talked about, but I'd like to say this on the record, but also say this again. And just even in light of our media has ways of getting things out there sometimes. And I want to just say, for me, when it comes to what we do as a region, it's important that we are able to cover our officer the best we can, and making sure that the statements and things that are said into the public are things that we have agreed to and talked about. And when it sits outside of that, that makes it very difficult for me. And so with that said, I know it's very difficult when we're facing tumultuous times and we have people saying this or doing this. And so it would probably my only main encouragement is making sure that we can fall under that umbrella, that I, as a board member, can cover those kind of statements. And there's times I've not been able to. Now, he knows exactly probably what I'm saying, but I want to have it on the record. But I also want it on the record to say I do look at everything that has happened, and you've done a great job in a lot of ways. You've sacrificed. We have an incredible staff. You have a team that you put together. So those kind of things I want to say as well. But if there's an area that I would challenge when it comes to our region, is we have to collaborate well together. And it's not easy sometimes, but we need to make sure that that is represented, in my opinion, of our board, but also the best collaboration. Thank you.
Thank you, Councilman Dare. Any other comments by members of the board? And I'd just like to echo what Councilman Dare said again, because you're right, the extension that you are for the board members here, Kevin, and I got to say, over the years we've worked together and had our discussions, you've always been open to new ideas and ensuring that you're meeting with us to keep us apprised of what's taking place. And man, has it been some difficult times for the last couple of years, and we appreciate that. And I know, you looked at the areas, we talked about this early on, of areas that you need to improve on or work towards improvement. And again, I think you've done a phenomenal job with your staff and all directing what's taking place today, as well as the past couple of years, and we appreciate that. And so if there's no other comments or questions, we can go ahead with the motion, if we'd like to see a motion.
I want to echo the same thing, absolutely. And
I want to turn on your microphone.
okay, yeah, please. Now, I want to echo what Mr. Brown said, and it is absolutely true. Mike and I have worked with Kevin now for 7 years, and it's been from fun and kind of boring to absolutely tumultuous times, and I thank you very much for doing this, and I move to approve the health officer's annual performance evaluation results.
We have a motion. Do we have a second? Second by Dr. Danko. Any more discussion? Let's all in favor signify by saying aye.
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 Thank you very much.
Dr. Clackings, is he still there? Okay.
I am here.
Okay, sir. Thank you.
I am here. Yes.
All righty. Now, did we have an aye from you there, Dr. Clackings?
Yeah, I'd probably rather abstain from that just because I wasn't involved in any of that evaluation and I didn't know it. So I think that might be best from my perspective on it. Not that there's anything I've seen that's wrong or anything else, but that was before my time. All of that happened. So,
Dr. Clackings, thank you for pointing that out. We appreciate that, and we noticed your abstention.
Yeah.
Thank you, sir.
Could I make a comment?
Yes, Kevin. Go ahead.
Just one thank you for those comments, and I really appreciate that you included what an excellent staff there is here, our division leadership, our supervisors, everybody on the ground that's been working hard. It's my privilege and honor to be able to lead them, and I think you appropriately acknowledge that what the health district has accomplished is largely due to their efforts. And I've just been fortunate to have them and be able to move us forward, and I'm grateful for my board and your support as well. So thank you very much.
Good deal. Thank you, sir. Okay, moving on to item number 15 is the possible approval of the proposed 2022 Washoe County Health Board meeting calendar. And District Health Officer Dick.
Yes, thank you. So we have the schedule for the board meetings for approval for 2022. And it's the same approach that we've used that's in our bylaws for the scheduling of the meeting, the fourth Thursday of the month, with the exception of November and December, where we are scheduling the meetings on the third Thursday because of the holiday conflicts. You'll note, though, in the calendar, we did not include a date for a strategic planning retreat. And that's because we are in discussions about how we want to approach the process of the strategic planning with the board for our update, or actually a full update in calendar year 2022. And it may be that we will have several different sessions with the board. It may be that we try to incorporate those sessions into the regular meetings. And so we'll come back with an agenda item for the board to present what we're proposing for the strategic planning process at a later date and do that separately from this calendar approval. I guess I would also just note I'm hopeful that even if we have this different approach for the strategic plan, that we may be able to have the November meeting as a tentative meeting type thing like we've done previously, and may be able to cancel that depending on what business we have going on. So that's my report. Thank you.
Sounds good. Any questions on item number 15 or comments? It's an action item. Can we get a motion?
I'll make a motion, but I want to request, July 28th is my birthday, and if I'm coming, I think a birthday cake is necessary.
Yeah, I'll make a note of that.
Do I have a second?
Oh, sure.
So we got a motion. Is that your motion, sir? Yeah. All right. Do we have a second?
With the cake.
Second.
Second by Dr. Clackless. All in favor, signify by saying aye. Aye.
Aye.
All right, motion carries. Thank you, Kevin. Moving on to item number 16, staff reports. Mr. Vega.
Thank you, Mr. Chair, or thank you, Mr. Brown. Members of the board, for the record, Francisco Vega, Director of the Air Quality Management Division. I don't have anything to add to my staff report, but I'd be more than happy to answer any questions.
Any questions for Mr. Vega on the staff report? Thank you, sir. I like that.
Thank you.
Moving on to item number A under 16, Community Clinical Health Services. Lisa. Ms. Lawrence.
I'm Lisa Lotridge, Division Director for CCHS, and I just have two additions, things I wanted to mention. In our report, we mentioned that we applied for the opt-out syphilis screening of women and other individuals of childbearing capacity in jails, and we were awarded this grant and through NACHO, and so we hope to have a scope of work in January, so we'll be back to share more about that. But we'll be working with Washoe County Sheriff's Office and NAFCARE on this project, so that's exciting.
Good news.
And then the other thing, I just want to let you know that the federal WIC waiver was extended into January, so that clients can continue to be seen remotely. And we should know more. This is going to be revisited mid-January, so we should know more of how that's going to proceed for next year. And I'm happy to answer any questions.
Thank you. Krista.
I have one quick question.
Yes.
So looking just at your third quarter report of diseases and things, when there's such an increase, like a 34.7 increase, what do we do? I mean, I appreciate the report and I don't like thinking about it because I'm like, oh, all right,
Yeah.
but reality is that's a pretty huge increase. And with that said, do we just sit back and watch it and go, oh, that's still getting bad?
No, it's significant. And I can tell you some of the things that we're doing. Obviously, this grant, we hope will help. I assume you're speaking of syphilis.
Yeah.
Yeah. So hopefully this grant will be one way, increased testing. And then something else that we instituted in the clinic, whenever we have someone come in and they have a positive pregnancy test, we automatically do a syphilis test, and vice versa. If they're positive for syphilis, we automatically do a pregnancy test. Those are just two things that we've instituted in our clinic. Increased testing. If we're doing this at the jail, it's not going to just be females that will be tested, but hopefully it's going to increase testing for males as well. Not having the outreach clinics that we did because of COVID, not being able to go, I think that was not helpful for us. So now that we're able to get back out there in the community, I think we get more testing. If we're testing, then we can get them treated in a timely manner. All of those, I hope, will make a difference. The Congenital Syphilis Review Board was just started in Washoe County. So there are definitely efforts that we're working on. We also received a supplemental STD grant and have our first epidemiologist in the sexual health program. So definitely trying to get more efforts out for this, but you're right, it's concerning.
Yeah, thank you.
Any other questions from any board members?
Yeah, this is Dr. Clacking. I just had a question. Is this, you may have addressed this, but is this the same pattern we're seeing nationally?
As far as increase in syphilis, yes. Yes. Primary and secondary infectious syphilis is on the rise.
And do we know the reason for that? There's obvious reasons, but yes.
Yeah, I'm not sure if we know the exact reason. Not that I'm aware of, no.
Okay.
Sorry, I don't have a better answer for that.
That's okay, that's okay. Any other comments or questions? All right. Lisa, thank you very much.
Thank you.
Moving on to Environmental Health Services, Ms. Dixon.
Good afternoon. For the record, Erin Dixon, Director of Environmental Health Services. You have the report in front of you. The highlighted program this month was the food safety program. The last picture in that is the Washoe Eats app. If you haven't yet had a chance to download that app, I highly recommend it. It's public, easy access to our food inspections for all of our facilities. There's approximately 3,700 food establishments in Washoe County, and that is where we make those inspections publicly available. Just besides that program, I want to highlight two other things from two other programs. Are with our child care inspections. The Human Service Agencies in October, they changed their child care regulations, environmental health sections to not allow any child under the age of 12 months to sleep in anything except for a crib. So, the swings, the bouncies, those different types of things. So our team is working very closely with HSA and our child care facilities to educate the teams on the changes that need to occur, and then also to change the way we do our inspections for those facilities. And then finally, it is reported that our safe drinking surveys, that there were 4 remain to be conducted in 2021. And since this report has been written, all 4 of those have been completed, and we are 100% complete for the year. I'm free to answer any questions that you might have.
Any question by the board? Good, looks good.
Okay, thank you.
Thank you, Ms. Dixon. Moving on to epidemiology, public health preparedness, Dr. Dow.
Good afternoon, members of the board. This is Nancy Dow, Division Director of Epidemiology and Public Health Preparedness. 2 things I want to highlight today. On December 6th and 7th, our public health preparedness team went through a 2-day training on medical countermeasures pod at the REOC. The training was FEMA funded, offered through Texas A&M Engineering Extension Services National Emergency Response and Recovery Training Center. Other than the Washoe County Health District, hospital, fire, CERT, MRC, and the Washoe County School District also had representatives that attended the training. This training focused on a time-sensitive event that would require community response and distribution of medical countermeasures to the exposed populations within an immediate and limited amount of time. The Public Health Preparedness Program team usually goes through these trainings and exercises regularly throughout the year, and these serve to help us improve coordination in planning and responding to public health incidents and support improvements in existing plans and learn about access to resources that may be helpful in the future. In epidemiology, so outside of COVID and other respiratory diseases, we're starting to see a bit more ILI activities and more confirmed flu cases. So in Washoe County, we're seeing more influenza A right now, in particular the H3N2 subtype. This is also the case around the US right now, where the H3N2 subtype is the dominant reported strain. So years with H3N2 increases usually tend to result in a worse flu season. So we're keeping an eye on that. And influenza A strains, especially H3N2, tend to have more genetic variants, so it's easier to escape immunity. And influenza B strains are more genetically stable in comparison and generally cause less outbreaks than A. But data has shown that it tends to skew towards more younger children. So last year's flu season, as we all have seen, was an odd season because there's minimal flu presence due to closing of operations and lots of social distancing. But before that year, we had been hit with several seasons of double-barrel flu seasons, meaning two flu strains outbreaks overlap following one another. For example, in the 2019-2020 flu season, influenza B was followed by hit with influenza A, and double-barrel flu seasons usually result in more hospitalizations and longer seasons. So far, up until this point in our current flu season, flu hospitalizations in Washoe County in our surveillance have not shown any noticeable upticks yet, and we're not seeing double strains. But we still need to keep in mind that we still got COVID, so there's a potential of going to maybe a double-barrel respiratory virus season with flu and COVID together. So we still need to remain careful with our masks and our vaccines. And our RSV numbers also continue to be on a steady climb up week to week since November. And that's all my update. I'm happy to answer any questions you may have.
Questions for Dr. Novak? There you go.
There we go. Okay. I do want to comment on the course that was given a week ago. It was absolutely an incredible course, well planned, well taught. I didn't learn a lot, but it was an affirmation, two-day presentation. Washoe County District Health Department like this did an absolutely amazing job. Even the instructors that go around the nation said, wow, you guys did it. They picked up things that we did and took it back to theirs. I think it was just an amazing experience knowing Washoe County did it right from the start, and we did it without a book from FEMA or anybody else. So I just want to tell you how proud I was of belonging here, working here. And the last thing, for those weak of heart that have missed it, tomorrow's the last pod. It will be 16, so make sure you bring gloves and a hat and come out and visit us tomorrow. Thank you.
Any other comments? Thank you, Dr. Dow. Moving on to item number E is Office of the District Health Officer. Officer Hill.
Yes, thank you, Chief Brown. I already provided a COVID update. I just wanted to highlight a couple of things. We did receive notification from the Public Health Accreditation Board that they accepted Section 2 of the annual report that we're required to provide them to maintain our accreditation. So we've successfully done that, and we're now proceeding with working on the reports that are going to begin being due in August of 2022. And then the board had provided me approval, the health officer approval, to add new fees for CCHS for medications, treatments, et cetera, as they become available. And so I, as per that approval, included the fees that we are adding for COVID administration. This will be in our clinical setting, in our IZ clinic when we're administering COVID. do have the opportunity to be reimbursed from insured patients for administration costs on the COVID. This will not apply to the community pods, homebound events, et cetera, things that we're scheduling with the Salesforce platform for the larger throughput vaccine events. So, and we will not charge if people don't have the insurance coverage for reimbursement for this. So included that in my report as well. And that concludes my report. Be happy to take any questions.
Any questions for the health officer? Okay, with that, we're moving on to item number 17 is board comments. Any comments from the boards? Councilman Dare.
Happy New Year, happy holidays. I hope everything does well and stay warm out there and stay safe. Thank you.
I think the same thing goes for all of our board members and our chairman. We want to thank everybody for everything you've done this year, the prior years. Have a safe holiday season, and I know we'll have a meeting next month. I'm sure there'll be interactions in between now and then. But thank you for everything, and with that, we'll go ahead and close the meeting. Dr. Cackling, thank you for attending by phone, and to the members that showed up today, thank you.
Thank you.
Thank you.